Today we're going to talk about electrocochleography. It's one of the most common tests ordered by ear, nose, and throat physicians. Sometimes we abbreviate it and just call it ECoG. We're going to be using the Inter-Acoustics Eclipse Advanced Auditory Evoked Potential System to do our measurement today. This system is ideal for this type of thing. Electrocochleography is not a new test. In fact, it's one of the very first tests in auditory evoked potential to be done. You can see here by these two publications as early as 1930. So it's been around for a while. And why would a physician order an ECoG? Well, simply because it's an objective confirmation of Manures disease or endlymphatic high drops. The symptoms of Manures disease are pretty broad, and they can also be the symptoms of other conditions. So the doctor would love to have an objective confirmation before he makes a definitive diagnosis. And the CPT code is 92584. And just to give you a definition of Manures disease, it's an inner ear disorder that affects both balance and hearing. Manures disease occurs when part of the semicircular canal called the endlymphatic sac becomes swollen. This sac regulates the fluid pressure in the canals, so excess pressure results. And therefore, one of the symptoms is dizziness. So let's talk first about the Electrode Montage. Okay? This is an ipsilateral ear-specific test, right? And the most common types of electrodes that are used are called tiptrodes. They're actually gold foil enclosed insert earplugs that are inserted deeply into the ear canal, and that's how we actually pick up the response, from the ear canal. And I'll show you those in a minute. An alternative to that is a TM electrode. TM meaning tympanic membrane. So this is an electrode that actually sits right on the tympanic membrane. The third would be a transtympanic electrode that goes through the tympanic membrane and is actually placed on the promontory. That is rarely done. The most common is tiptrodes. Next common would be the TM electrode. And as far as the electrode montage arrangement, if we want a positive going action potential, the action potential is wave 1 of an ABR, but if we want that to be positive going, as most audiologists in the United States are used to, then this is the montage that we want. We want the test ear, the ear that we're stimulating and testing, we want that to be the reference electrode or the negative electrode, sometimes called the inverting electrode. And we want CZ, high forehead, to be the active electrode or positive electrode, sometimes called the non-inverting electrode. And ground or common can be on the lower forehead or even off to the side if you want. The important thing is that no matter how we make this measurement, unless we use a transtympanic electrode, the measurement is going to be a far field measurement, far field. That means we're pretty far away from the actual generator of this response. You know, the generator of the action potential is the 8th nerve action potential, right? So when we're in the ear canal, we are far afield of the actual generator of the response. So for that reason, we need a deep insertion. So you're going to insert the tiptrode deeper into the ear canal, much deeper than you would a typical insert plug, right? This graph will show you what difference that makes. We never use mastoid placement in electrocochleography because the amplitude of the response will be way too low. But you see the amplitude rises as we get closer to the generator, the further into the ear canal that we get. We would be a little bit better on the earlobe, but we're much better if we're in the ear canal. And then if we are deeper and deeper into the ear canal, you see that the graph goes upward, and we get a larger amplitude response, and we want that if we're going to be able to identify the components that we need to be able to identify and mark. Naturally, if we use a TM electrode, we're even a higher amplitude, and if we actually use a transtympanic electrode placed on the promontory, then it's even a higher amplitude. So the first thing that students have to learn about this, since they'll be doing most of their patients with tiptrodes, is that you're using the smaller tiptrode, the one that you would normally use on pediatrics. In most cases, you're using that so that you can place it very, very deep in the ear canal. This is what the TM electrode looks like. It's a little gel. We put a little bit of gel at the end of it, electrode gel, and it actually sits on the tympanic membrane. Now, this cannot puncture the tympanic membrane, so there's no danger of that, and there's not a lot of discomfort for the patient. However, it takes practice to get good at that so that it's placed directly on the tympanic membrane and that it stays in place during the test. It has advantages, and the advantage is that you get a higher amplitude, and you may be able to test patients that have a greater degree of sensory neural hearing loss. Okay? So to use a TM electrode, which actually comes with this equipment, would not be a bad idea. It's just going to take a little bit of practice to do. I know audiologists that insert this all the time, and some of them have a PA in their practice, or the physician themselves do it. And once they get used to doing it, then it's not a big deal for them. But still, most audiologists use tiptrodes. Okay, that's further field, so it's less amplitude, but on many, many patients, you can do this. And here they are. They're just like the insert earplugs, and they have gold foil around them. There's actually 24-karat gold foil. And the leads that we would use for tiptrodes, these are what come with the Interacoustics Eclipse, they are like little alligator clips that are going to clip onto the end of the foil. They're rounded alligator clips so that they're easy to just clip on to the foil. You got to make sure you got the end of that gold foil. Because we're doing two things here. We're using these tiptrodes to actually collect the response from the ear canal, from the external meatus itself, and we're also using it, of course, to deliver the stimulus right through it. Okay? So these are the leads that we would use for the tiptrodes. We find these leads better than any other lead. Okay? They're less prone to have problems over time. They're very simple to use. They're ideal. If you were using a TM electrode, this would be the electrode leads that would come with it. And you notice that there is a place where you would plug in that tiptrode, that disposable, naturally use only once, tiptrode. And then there are two leads that come off of it. The next slide is going to show us how we would plug the TM electrode leads into the patient cable. There's a special patient cable for this, just unplugged from the preamp, the patient cable that you would use for ABRs and VEMPs and other things like that. And then you would plug in this special cable. There's only 3 electrode connections here. So you have the green connector that's on the leads, which is this one, and that's plugged in. That's plugged into the ground. Ground is green, and you plug a black electrode into that, and that ends up being your low far head, or you could put it off to the side if there's no room on the low far head. And then plugged into the white lead. This is the positive lead. This is for the action potential going upward. Plugged into the positive, white, is the white lead, and that would be the upper far head. And then, of course, that red one is the actual, leading to the actual TM electrode. Here the TM electrode is plugged into that little connector. So I hope that makes sense. This is a good slide to keep for anybody who's going to be using TM electrodes. When we use the Tiptrodes and the Tiptrode lead, it's simply like this. We're going to use a Tiptrode instead of the regular insert earplug, and then we are going to just connect that special rounded alligator clip to it, red for right and blue for left, and plug those into right and left on the regular patient connector. There is an alternative Tiptrode leads. Many times if you just order Tiptrode leads, this is what you get. Almost everybody that's using Tiptrodes that I know use these, even though we recommend the ones that come with the Interacoustics Eclipse because they are just more durable than these. After a while, these wear out and they don't make a good contact with this foil. So either one of them is usable. Okay, so now that you know the Electrode Montage and you know about the alternatives for types of electrodes, we'll talk about the actual test results. This particular diagram is an ECoG response. This is what you will see in virtually every textbook when it starts talking about electrocochleography and the responses. And it's negative going, so it's good to get used to this as negative going, even though when you do it, you will, the montage that we recommend and that we've given you is for upward going, because in the United States, that's the way most people like to do it. Anyway, what you'll find is, and this is the action potential. The action potential is wave 1 of an ABR. This will be probably a higher amplitude than you're used to seeing for wave 1 because we're a little closer field. We're in the ear canal rather than on the mastoid or the earlobe. And prior to that, just before that, there's another small wave which is the summating potential. And it is the ratio between the amplitude of the summating potential and the action potential that is going to be what we're going to take into consideration here. So let me just continue. The next slide is going to show you what this would look like on the equipment using the montage that we gave you. It's probably the way that most audiologists in the United States would represent electrocochleography, like this. I did this one on myself on the Interacoustics Eclipse, and here are the results. And you can clearly see the action potential. I always mark that first. And then I move left as if this is a mountain. And once I leave the peak of the mountain and descend, I get to a little foothill. Well, that foothill is the summing potential. Sometimes it's a discrete wave right before the action potential, as it is represented here. But many times it is a small wave form that's on the leading edge of the action potential, as you can see here in these test results from my right and left ear. Oh, and by the way, I don't have perfect hearing. I have a mild sensorineural hearing loss. So you can do this test if we do it properly, taking into consideration all the things we're going to talk about, with patients that have a mild high-frequency sensorineural hearing loss, which many of them will. However, as we'll see shortly, when there's a sensorineural hearing loss that's too great, then we're not going to be able to do it like this. We're going to have to go to a TM electrode in order to be able to test patients with a greater degree of sensorineural hearing loss. Okay, so what about the test protocol? We talked about the electrodes and the montage and basically what the waveform is going to look like. Let's talk a little bit about the test protocol. Well, the stimulus are clicks, and they're 0.1 millisecond clicks, the same type of click, the same exact click we would use for a click ABR. And the rate's going to be slower than we're used to for ABR. We like the rate to be 7.1 or 7.0, 7 clicks per second or slower, right? The slower you go, the better the wave morphology is. So a slow rate in this. So it's going to take a little while, but it's not too bad. And the polarity has to be alternating, not a condensation click or a rarefaction click, an alternating click. And the reason for that is we want to actually see a summoning potential, the actual summoning potential. And we don't want that to be obscured by a cochleomicrophonic. So naturally the alternating click will cancel out the cochleomicrophonic and leave the summoning potential for us. Okay? The intensity is high, right? We always go 90, our default is 95 dB. And if the equipment allows you to go higher, we can go higher than that on the Interacoustics Eclipse, then we do, especially if the patient has some hearing loss. The transducer, of course, is an insert, and masking is never needed because this is an ipsilateral response. Continuing with the test protocol, the amplification is the same as we would use for ABR. The size of this response, around 1/2 microvolt, 3/4 of a microvolt, is the same as an amplitude as a typical ABR wave 5. Now the analysis time, instead of 10 milliseconds or longer, as we would use for ABR, the analysis time is going to be 5 milliseconds. And we need to do at least 1,000 sweeps, and maybe more. We might go up to 2,000. Don't often have to go to 2,000, but we might. I don't like to just stop at 1,000 or stop anywhere. I like to stop when I have a nice repeatable response. And as far as my filter settings, my digital filter settings, the high pass or the low end of the band pass is either select 1 hertz, 3 hertz, or 5 hertz. That's very important because you will not get a summoning potential if you select something higher. Some equipment, it's automatically 10 hertz or even 30 hertz. Okay, well, that's a mistake. It needs to be as low as you can go. Okay, as far as the low pass filter or the high end of the band pass, we typically start that around 2,000 hertz. So the band pass is from 1 hertz to 2,000 hertz. And then here's what you'll get, of course, if we did condensation or rarefaction. We would have this cochleomicrophonic, which would distort the actual summoning potential. So we don't have that because we're using an alternating click, and we end up with a summoning potential, an action potential, and a summoning potential. In this case, it's riding on the leading edge, which is very common, and sometimes it's not that easy to see it. It takes some experience, and I'll share with you a technique that you can use to bring that out if you need to. Remember, our analysis time, you can go 10 seconds. A lot of people do, but I like better at 5 seconds, 5 milliseconds. All right, okay, we're looking at this upside down, but this is, as I say, typically what you'll find in every textbook. And what we're interested in is measuring the amplitude of the summoning potential and the action potential. So we've got to identify the peak of the action potential, the peak of the summoning potential, and what's called the baseline, or the bottom of the summoning potential. Right? We've got to identify those and mark those 3 places. Okay? And then what we're actually going to do, the equipment's going to do it for us, is we're going to figure out the amplitude of the action potential from the baseline to the peak, and the amplitude of the summoning potential from the baseline to the peak. And then the equipment will compute the SP-AP ratio, amplitude ratio, and that's going to be the indicator of a positive or negative test. Flip this around, and the way that we normally represent it is like this. So a lot of times I say, hey, if you're up on the mountain of the action potential and you take off down the mountain and eventually you come to this foothill. The foothill is the summoning potential. You get to the bottom of the foothill, okay, then that's the baseline. Now let's look at the effects of a moderate or severe high-frequency sensorineural hearing loss. All right, so this particular case, patient has normal hearing in the left, but in the right, they have a good degree of sensorineural high-frequency hearing loss. Notice that the threshold at 2,000 is okay. It's 25, but then it's 60 dB at 3,000 and 4,000. Well, that's going to affect our test results. And so here's what we got on that patient. In their good ear, right? Remember, their good ear was the left ear. In their good ear, we got a good-looking response. We have a clear action potential and a clear and repeatable summing potential. So it's easy to mark action potential, summing potential, and baseline, and have the system compute the amplitudes and the amplitude ratio for you. Yet, on the right ear, the ear that had all that sensorineural hearing loss, we got no response. You don't want to be taking something like this and trying to mark it. This is just no response. And that's due to the sensorineural hearing loss. Here's what an abnormal response would look like. Remember that Manures disease and lymphatic hydrops, right? It actually increases pressure in the vestibular system, and it's that pressure that elevates the summing potential. So normally, the summing potential here is less than half the amplitude of the action potential. Normally, the summing potential is less than half the amplitude of the action potential. And so it's relatively low like that. In a case of Manures disease, look what happens. The summing potential is all the way up here, greater than half the amplitude of the action potential. So normal versus abnormal. Okay, so here are the ECoG rules of thumb. We call them rules of thumb because they are variable, but they're really good to know. You're going to find the action potential when you do this at 95 dB, around 1.5 milliseconds. You're going to find it, if you're going to find it at all, you're going to find it around 1.5 milliseconds. And I always look for this first. You have to have an action potential, and that action potential has to be clear and repeatable if you're going to have a test at all. And so mark that and find it. And where's the summing potential going to be? It's going to be to the left of the action potential, and you're going to find it somewhere in between 0.5 and 0.8 or 0.9 milliseconds. And so move back 0.6, 0.7 milliseconds from the action potential, and you should be very close to it. Okay? That's a good tip to know. And then what's normal, what's abnormal? If you're using Tiptrodes, then the SPAP, the summing potential, action potential, the SPAP normal amplitude ratio for Tiptrodes is less than 0.5 or 50%. That amplitude needs to be less than half of the amplitude of the action potential. If you're using TM electrodes instead of Tiptrodes, then the SPAP amplitude ratio that's normal would be less than 0.35 or 35%. And the sensitivity of this test is approximately 63%. All right, so it's not the most sensitive test in the world. In other words, the positive predictive indicator is about 63%. I'll show you how you can increase that in a minute. Another important thing is the electrode impedance. Many people that do this, they don't prepare the ear canal properly. And so they always have high impedance, higher than they typically have with surface electrodes when they do an ABR. That's a big mistake, okay? You want to get an impedance that is 5K or less in the ear canal, right? And you want both ears to be within 3K of one another. So not one's 1K and one's 6K, right? Then they're pretty far apart. You want them to be within 3K of one another. Pretty close impedance left to right. And the reason for that is you optimize the effectiveness of the differential amplifier and its common mode rejection of artifacts when you do that. And of course, all of this affects the wave morphology, repeatability of the response. Most audiologists try to insist on what we call the 2K, 4K, 40 rule. 2K, 4K, 40 rule. What do I mean? In between 2K, that's 2K, 3K, and 4K, none of those thresholds, hearing thresholds, are 40 dB or more. They're all better than 40 dB in that frequency range, 2K to 4K. So it's 2K to 4K, 40 rule. You can try it at 40, but never over that. Many places say it's got to be actually better than 40. So anyway, that's a good tip. It's a good rule of thumb. If you want to enhance the sensitivity of this test, one way to do it is by making ECoG area measurements. So we're measuring, well, it used to be called area under the curve, not just the amplitude ratio, but the area ratio. And I'll show you what I mean by that. The normal SP-AP area ratio measurement is going to be somewhere between 1.02 and 1.94. Anything greater than 1.94 is abnormal. And now we've raised the sensitivity, the positive predictive value, from 63% to 83%. So we're more likely to actually be able to identify the patient with a test that's positive for Manures. Okay? And this type of measurement is built into the Interacoustics Eclipse Advanced Auditory Evoked Potential System. It's one of the reasons why we call it advanced. Anyway, if we were doing just the amplitude ratio, we would mark the base, well, mark first the action potential, and then the summating potential, and then the baseline, the bottom of the summating potential. And that would be all. It would calculate the amplitude ratio. And anything less than 0.5 or 50% would be normal. Over that would be abnormal. But when we do the ratio, we do a little bit more. And we're going to do this test, and we'll show you how you do all of these in our next little segment. But what we do is we mark the baseline, and the system marks two places, baseline start and baseline end. Automatically marks the baseline end, but you can move it if you disagree with it. And then, of course, the summating potential peak, the leading trough of the action potential, the peak of the action potential, and also the ending trough of the action potential. We're going to mark all those things. Now it's no problem. I mark it within seconds because I'm used to doing it. And you'll see, because we'll do that live for you in the next segment. Okay, so what do you get? If you did amplitude ratio, well, you'll simply mark those three places and you will get an answer like this. In this case, on my left ear, the AP-SP amplitude ratio was 0.219. Well under the 0.5, that would be abnormal. If we did area, here I did area on the same test, my left ear, and the area is 1.321. Remember, anything that is lower than 1.94 is normal. But the thing is, I've raised my sensitivity. Now I'll show you even another way to raise it another notch, up to 85%. And that's this. On the Interacoustics Eclipse, as you collect your ECoG response like this, you are actually collecting two waves in the background. We're using an alternating stimulus, But this system can collect two waves in the background. It can collect a condensation and a rarefaction. After all, an alternating click is made up of a condensation and a rarefaction click. Well, the system is automatically collecting both of those in the background, saving them for you, and with one button will display them. So now we're just looking at the action potential, not the summing potential. That's all distorted by the cochlear microphonic, but just the action potential. And we notice there is a difference between the condensation and the rarefaction. I don't even care which is which, but there is a difference in latency. Well, that is the indicator, that difference. If the difference in latency between the condensation and rarefaction action potential is greater than 0.38 milliseconds, then that's an indicator of abnormal. Add that to an area measurement instead of simply an SPAP amplitude ratio measurement, and now you've really increased the sensitivity from 63% to 85% of the time you'll be able to have a positive indicator of Manures. Last slide, don't panic. Okay, these are some tips for people who do ECochs. I've been doing this for 40 years, so I have seen all kinds of problems. Today, with our equipment, with the type of processors that we have, digital processing that has evolved through many algorithms over the years and has become so high performance, noise immune, we're getting much better results. We're able to do things that couldn't be done in the past. But things that'll help. The shorter test leads. The TM electrode leads that we recommend, those rounded alligator clip leads, special leads that come with the Electroacoustics Eclipse, they are shorter than the other Tiptrode leads, those alternative Tiptrode leads, and therefore they'll pick up less electrical interference. So if you're having electrical interference problems, using those, that alone might solve it. And in many cases it does, just that. It's like a miracle. It's also important to consider the lead dress, and by that I mean keeping the electrode leads separate from the insert receivers. Don't have them wrapped around or running across the inserts themselves when you have them clipped onto the patient's clothing. Just keep them separate so we're not picking up a stimulus artifact. If you have to use long electrode leads, like they're 42 inches or something like that, consider braiding them along with the ground electrode. All right? That acts as a type of a shielding. Remember the electrode impedance match. All electrode impedance is below 5K, and the electrode impedance of right and left Tiptrode are within 3K of one another. The low pass filter, that's the high end of the band pass. If you had it at 2,000, if you had it at 3,000, lower it to 2,000. If you had it at 2,000, you could even go to 1,500 or even squeeze it down to 1,000 if you had to. All right? I'd rather a little bit broader, like we originally recommended, but you could squeeze that down. Don't change the high pass. If it's 1 hertz, you can move it up to 5 hertz, but don't go any further because you're going to obscure the summing potential. Okay? That's important. A power line filter. The brand name that we use is Monster. You can get it at Best Buy. And it's not in the computer section. It's in the audio section. And it's not, it looks like it just looks like a regular bar of electrical outlets, right? An outlet strip. But it's a special outlet strip that has a line filter in it, AC line filter in it. And it makes a big, big difference where interference is coming through the power system of the building, okay? So that power line filter is excellent. It costs you about $129, and in many, many cases, we plug the equipment into that, and presto, interference disappears, okay? Also, on a system like the Electroacoustics Eclipse, we have offline digital filtering. So we can filter the response even after we get it. We say, boy, we'd like it to look a little bit better, and we can tweak the filtering even though it's done, as if the filters were originally set somewhere else. Another thing we could do if we want to enhance the response increase the amplitude a little bit, get a little bit of better wave morphology and repeatability. Remember, if it doesn't repeat, if it doesn't replicate, you have to investigate. Right? That's necessary to know you got an actual response and not just a random response. Anyway, we could use a horizontal montage. In other words, instead of collecting from CZ to the ear canal, we would collect between the two ear canals. So that would take a rearrangement of the electrodes, but it could be done because that will give you a higher response. And if you can't identify the summing potential, there is a little trick. Sometimes it's on the leading edge of the action potential, but it doesn't have a little edge on it that you can mark with experience. It's just like it's almost not there. If it isn't, this case is probably normal, because if it was abnormal, that summing potential would be exaggerated. But anyway, in order to find it, what you can do is increase the stim rate. Increase it to 30, 40, 50 clicks per second. You will diminish the action potential, but the summing potential should then stand out. Okay? It's a little trick that could be helpful in certain cases. Remember to use the smaller of the tiptrodes. What you would normally think was an insert earplug for pediatric. Even use those on most adults, unless they have a huge ear canal, so that you can get a very, very, very deep insertion. Don't be afraid of it. That's what makes all the difference in the world. Make sure when you clean the ear canal, in order to get super low impedance, you're doing it with an abrasive, right? Like New Prep, right? You can use alcohol on a Q-tip, but also New Prep. So you're degreasing and abrading the skin in the ear canal. And of course, a very deep placement makes all the difference. So those are the tips that will help anybody who's already doing this test, and we hope that this presentation has helped you in knowing all the alternatives and giving you some tips that will improve the results that you're getting. And now what we're going to do is we're going to use the Interacoustics Eclipse. We're going to show you how we actually apply the electrodes. We're going to do the test and show you how we analyze the test. In this segment, we're going to talk about the ear canal prep and the application of the tiptrodes. Okay? So there's several things that are very important here, and the ear canal prep is like the skin prep. Once you're doing an ABR, it is critical to getting good results. So we're going to be using a tiptrode, right? And we're going to be, therefore, prepping the ear canal. And this is how I do it. I like to do two things. I like to degrease and abrade the external meatus. And the way that I degrease is simply by applying some alcohol to the Q-tip, like I'm doing now. You can just dip it in isopropyl alcohol. And the next thing, very, very important, is to use New Prep. So I take some New Prep and I just take, a little dab of it, and I make sure I've got it really pretty good on this Q-tip, but not so much that I'm going to occlude the ear canal with it. Right? Then I'm cleaning nice and deep. Remember, because I'm going to get very deep placement of the tiptrode. And I'm doing it all the way around the ear canal, nice and deep, and I'm doing two things now. I'm degreasing and I'm abrading, and it is best to be aggressive. Most audiologists, when they start skin prep, and especially ear canal prep, they're not going deep enough and they're not aggressive enough. We must abrade it because we want an impedance that is somewhere between 1 and 5K maximum. Okay? Another thing that's important is the electrode gel. This is conductive, electrically conductive jelly. And the way that I do it is I just put some gel around on this, and as I'm compressing this, compressing the tiptrode, I've got it compressed, and while it's compressed and I've got gel on it, that's when I'm inserting it into the ear canal, as you'll see when we actually do that particular segment. I also naturally have that connected to the insert phone, and I'm going to connect to it now once it's in the ear canal, deeply inserted, and I'm going to connect this little alligator clip. It's a rounded alligator clip that's just perfect. I'm just going to connect that on the end of the stem, the end of that stem, making sure that I actually have that wrapped around the gold foil. And I'm going to plug that in right into the red connector, left into the blue connector, and of course the white one will be on CZ, the high far head, and the black one's the ground. That would be low far head. If there's no room on the low far head, then of course you can offset it on the side of the far head if you had to. And so that's the ear canal prep, very important, and the prep of the electrode itself and that deep insertion of it. What's important here is that we use new prep because we're abrading, and it's also important that we don't get new prep lodged in the ear canal as to cause an occlusion, which will diminish the intensity of the stimulus, and that when we insert this, we're using that conductive gel on it. As we're compressing it, we can apply the conductive gel. That makes all the difference in the world in getting good impedance. Abrasion and conductive gel, and of course we have a very deep insertion. So now we'll show you how we actually do that. Okay, so now I'm all hooked up and plugged in, and we're making sure that the left ear is selected because that's the ear that we're testing. We want to make sure we're stimulating the left ear, and we want to make sure that at least 95 dB is selected for intensity. Once we're sure we got everything, we got the right protocol selected and all, our EEG looks good, we'll just go ahead and hit start. Okay, now we've completed the test and we've run a replication, and so we're going to mark. What I do is simply choose which are the best of the two. They've replicated. In fact, I can superimpose this like this to make sure that I've got good replication of both the action potential and the subbing potential, and I do. Choose the better of the two. They might be absolutely identical. They would be if you let it run long enough. But anyway, in a practical sense, there'll be some differences, and you choose the best one. And then this is the way that I mark the amplitude. Now we're just doing the amplitude ratio. And so I start with the action potential. Right? That should be very obvious. And I mark the peak of that. Then I go to the summing potential, and there it is. Here it's on the leading edge of the action potential, but it's clearly there, and that's where I mark it. It takes a little bit of experience to know this, but that would be where I'd mark it. And now, a lot of times the baseline is a problem, figuring out where to mark the baseline. You see, I'm going over to baseline to choose that mark, and notice the trough, the trailing trough is what I call it, of the action potential. And if you were to measure, or to have an imaginary line over from that to the summing potential here, to the leading edge of the action potential, and you mark that, that's where the baseline should be. Not here. Right? If you did that, then you'd be misinterpreting that. That's way too soon for the baseline. That's even before 0. You notice I have this starting at -5 milliseconds. Anyway, so here's my marks of baseline, summing potential, and action potential. And if I go over here, the system has computed my SPAP amplitude ratio, and it's 0.404. Within normal, because an abnormal would be a SPAP ratio of greater than 0.5, or 0.5 or greater. So that would be the end of my analysis. I would say that's normal, it's negative, it's not an indicator condition of Manures disease. Now that we have labeled the action potential, the summing potential, and the baseline, and we know the AP-SP ratio, SP-AP ratio, now that we know that, right, and it's within normal, it's 0.404. It's the amplitude ratio. Now we're going to look at something else that's going to increase our sensitivity a little bit more. We're going to look at the rarefaction and the condensation component. Remember I told you that in the background, the interacoustic eclipse system is measuring two waves in the waveforms in the background. It's doing condensation and rarefaction. They're components of the alternating stimulus. So if I just click on AB up here, I get those two waveforms, the condensation waveform and the rarefaction waveform. And so I'm going to place a cursor. I'm going to go over to my waveform and I'm going to select cursor, and I'm able to mark the peak of one of these, let's say it's the condensation, and then move my cursor over to the rarefaction, and I can use my arrow keys to get it exactly where I want it to be. There it is. All right, so I've got one cursor on the peak of the action potential on the condensation curve, and one on the peak of the action potential on the rarefaction curve, and I want to know the difference. In this case, where I've marked them right now, the difference is 0.13. Remember that this difference would have to be 0.38 or greater for this to be an abnormal sign. Right? But that's normal, as well as my amplitude ratio, so I would be very, very confident in saying that this is a negative test, not an indicator of Manures disease. Okay, so now we want to increase our sensitivity, and we can do that by measuring the area and having the system calculate the SP-AP area ratio and not just the amplitude ratio. And here's how we would do it. First of all, I'm going to switch from having this system just calculate amplitude ratio to doing the area. And so I'm going to go to File and then System Setup, and under the General Setup tab, I'm going to select, instead of amplitude, which was selected, I'm going to change it to area. And then click on OK and begin marking. So we start with baseline start. The baseline start, you'll remember from when we marked it before. We're going to start it, baseline start right here. And it automatically marked the baseline end. Okay, you can correct that. It'll just draw a line straight over and call that the baseline end, and that's where it is, unless the waveform is such that it marks it somewhere else on the waveform, not even near the trough of the action potential. Then you can correct it and bring it to where it needs to be. The next thing to mark is the SP, summing potential, the peak of the summing potential. And so go ahead and mark that. And then AP1, that's the start of the action potential above the summing potential, AP1, the action potential peak, and then the trough, the actual trough of the action potential. And then if you go over here, you'll see SP-AP ratio, and it's 1.687. Remember that abnormal is anything that's above 1.94. And so that's an indicator within normal range as well. So now we really have three things. We have the amplitude ratio, as an indicator. We also have the difference in latency between the condensation and the rarefaction component, the difference in latency of the peak of the action potential. And then lastly, we can enhance everything as far as sensitivity by having a calculation of the area ratio. This will give us a high sensitivity, and it seems like a lot, but once you get used to this, it's very easy to run and mark, and you'll be doing electrocochleography every day with high sensitivity and good patient results.